Welcome to the Golden Hour, the podcast community where moms and moms-to-be hear stories from other mothers and top experts in the pregnancy and postpartum care field. You can visit goldenhour.fm for more information, resources, and all other episodes. You can also find us at goldenhour.fm on Instagram for comments and questions. Welcome to today's episode of The Golden Hour. I'm your host, Dr. O, and today I'm joined by my dear friend and former colleague, Martha. Dr. Martha Tesfalul is an assistant professor in the Division of Maternal-Fetal Medicine within the UCSF Department of Obstetrics, Gynecology and Reproductive Sciences, who cares for patients both at UCSF and the Alameda Health System. She received her BA in Sociology and her minor in Health Policy from Harvard University, and her MD with a concentration in Public Health and Service from Johns Hopkins School of Medicine. Martha completed her OB-GYN residency program and her MFM fellowship at UCSF. And during the latter, she also undertook the UCSF Preterm Birth Initiative, PTBi, research fellowship. While she grew up in Houston, Texas, she credits her deep roots to Eritrea, the country from which both her parents immigrated, for shaping her upbringing and her identity. Welcome, Martha.
Thank you, Dr. O. Excited to be here.
I always love, I know you well. We've known each other now. We've known each other now for 10 years. Wow. Yeah. That's a long time. But I love these interests because I honestly learn more and I fangirl hard. Like I knew you were legit. I knew you were really impressive, but I read that and I was like, she had time to get a minor. Like I was out there just trying to learn biochem and you decided to get a minor. I'm just impressed with you.
I appreciate that. I was a very curious person and, as you know, very indecisive. So that's why I ended up doing a lot of things. But look at you starting a podcast, getting information out, just really always admiring your creativity and excited to be here.
Look at us giving love to each other. That's what it's all about. Okay, well, Martha, maybe your curiosity is part of the answer, but can you tell us more about why you decided to become an OB-GYN to begin with?
Yeah. So I actually went to medical school thinking I was going to do pediatrics. I love family. And I, always grew up liking kids. I'm the eldest of 5 siblings. And when I started my clerkships in medical school, I kind of was thinking pediatrics, but ended up really loving my surgery rotation, loving my medicine rotation, and realizing that OB-GYN kind of allowed me to blend a lot of different aspects of medicine that I really loved, which included, being able to operate and do things technically and physically with my hands, but also to be able to navigate really important issues around reproductive health and how to build people's capacity around bringing life into the world. And there's nothing, a delivery. I still say every time I get to do a C-section or a vaginal birth, it's still insane that there's a new person in the world, a new individual. So I just loved it.
Yeah. It's funny because I too thought for the longest time I was going to be a pediatrician. And there was this moment where, I think it was it's still in undergrad when I learned more and more about the health trajectory that oftentimes the topics I was really interested in terms of neonatal health or pediatric health actually started as early as maternal health care. Now it seems so obvious, but at that time it literally blew my mind. And that's when I started kind of shifting my focus more towards women's health. So funny that you and I both were initially thinking that we're going to be pediatricians, but true OB-GYNs at heart, I guess.
I know. Now I hand off the baby and I'm don't ask me questions once they're out. But definitely I remember writing in my personal statement actually for OB-GYN, being overseas and doing pediatric rounds with doctors and seeing a newborn by themselves, who was very sick and wondering where was their mom and very much in agreement that so much of what sets children's lives up in the right direction is really supporting women to have healthy pregnancies and to be healthy even beyond their births.
Yeah. And so how did you decide, I spent some of the 4 hardest years of my life was in residency. I think you probably would agree. But also, I survived those 4 years because we had such a special class. And in our class, everyone took their own path. Did you enter your OB-GYN residency knowing that you wanted to be a high-risk OB specialist? Or was there something about that process that helped you decide that you wanted to become an MFM?
Yeah, I did have an interest in maternal-fetal medicine and gynecologic oncology when I was coming into residency, and actually during the first and second year of residency, thought about becoming a generalist. I think we had amazing generalists at UCSF. Now you are one of those amazing generalists, and the Sutter system, and just really liking the full breadth of OB-GYN. And I think it was really sort of, in second year, we get to do a rotation where you spend more time with the maternal-fetal medicine physicians on labor and delivery with the antepartum service, like some of our sicker moms. And I really liked the sort of collaborative nature, working with other specialists, really seeing kind of the full scope of medicine, but having to help patients navigate it, and really felt connected to a lot of the families that I ended up working with on that rotation, and felt like it was a great way for me to still be able to do, births and be engaged in that sort of fun aspect of pregnancy, but really also it piqued my intellectual curiosity, like just kind of thinking about all of the different conditions that can come up for patients that are pregnancy specific, but so many that are not. I just really found myself enjoying it.
Yeah. So for those in the audience who don't know what MFM, so maternal-fetal medicine specialist or perinatologist is, can you tell us in your own words what that is?
Yeah, it's an OB-GYN who focuses on taking care of patients with high-risk pregnancies. And that risk can be for different reasons. Patients can sometimes come into pregnancy with health conditions like lupus or renal disease, other high blood pressure, diabetes, that make navigating pregnancy a little bit more complicated and requires tailored care. Sometimes it's conditions that only become apparent during pregnancy, so conditions that can affect the newborn, even things like having more than one baby at a time can benefit from having a high-risk pregnancy specialist navigate the care. And then there are some pregnancy-specific conditions like preeclampsia, which when more severe, we get involved. Maternal-fetal medicine doctors, we also do a lot of ultrasounds. So we are often doing detailed anatomy ultrasounds, procedures that are ultrasound-based, like helping with genetic testing for patients who need that, or procedures such as transfusions for babies that are anemic before birth. And a lot of the inpatient care for some of our sicker patients who need to be hospitalized. It's a wide, some folks, MFMs are mainly clinical, some spend a lot of time in the hospital. I kind of do a little bit of both. So I see patients most of the time in the clinical setting, but do get to do some hospital-based care.
I think what I love so much about medicine in general, but especially the field of OB-GYN, is it truly is a team, right? That I grew up always playing sports. I'm kind of obsessed with like team-based analogies, and that I think the best model of care is one that doesn't rely on one clinician, right? Not only do you have like the primary OB, so the person that the patient might see in the office for the regular visits, you have the high risk OB specialist, you have obviously once you get to the hospital, the nursing team, sometimes even before delivery, anesthesia has to come in and have, give a consult. There really is this sense of togetherness. And so I feel very, not only do I admire my MFM colleagues, but I'm so grateful for them because it allows me to do my job really well. Like I can trust that you guys are taking care of the more, high risk and complicated conditions in a way that gives me the bandwidth I need to be a good doctor. That's always the goal.
Yeah.
And so tell us more about your fellowship. So the UCSF Preterm Birth Initiative, PTBi. Yeah.
PTBi. Yeah. So PTBi, that the PTBi initiative actually started with a focus in both California and in East Africa. I was mainly working with the California arm, and the focus was really on decreasing disparities in preterm birth in three main areas: San Francisco, Oakland, and Fresno. And Fresno being in the Central Valley, where we see some of the largest Black-white disparities in preterm birth. And I did this during my MFM fellowship, so it took some time to engage in this Transdisciplinary Research Fellowship, got to be in a cohort of some really amazing researchers. We were actually a group of all Black women when I was going through the training, and they had expertise in very different sort of aspects of social sciences, and we all learned about different research modalities and also got to work very closely with community and designing research projects that were responsive to what community members really felt would move the needle in terms of addressing these disparities. So one of the highlights of that research fellowship was getting to interact with the Community Advisory Board, or the CAB, of PTBi, which in part is maybe why I'm still at UCSF and working in the Alameda Health System. I still remember meeting Jennifer Braddock, who's a midwife at Highland Hospital, and meeting her while I was finishing up fellowship and doing this research project. And she was like, we need more Black midwives in the health system there. But also just, I really appreciated this idea of not generating questions in an ivory tower, but like really sort of being responsive to the needs and the questions that were identified by the people that were most impacted. And so I feel like it, to your point about like it really being team-based care, there's so much the pregnancy journey and even the postpartum period that is not within the healthcare system, right? Like I think connecting with doulas, connecting with, Black birth workers that are lactation consultants and things that are outside of the healthcare system. And also even thinking about the community at large, that is the village around moms that are sort of seeing these issues, their partners. I think that was a big thing in PTBi, was how to engage partners and sort of the care paradigm. It was really great. My project was mainly focused on preterm birth. Well, one of the projects I did was like on preterm birth risk counseling. Like, are we talking about it? Do people really understand what preterm birth is? And then also around kind of the use of aspirin for lowering the risk of preterm birth, and how do we talk about, or not for preterm birth, but preeclampsia, which can then turn into preterm birth, and how do we get that information out to folks? And it was a great experience.
Yeah, it sounds like it. And of course, my wheels are turning because there's so much more I want to learn from you related to the work that you did. Taking a couple steps back, just acknowledging that the audience might have different levels of understanding than you and I do. Can you tell us in your own terms, like what preterm birth is and what are some of the risk factors for preterm birth?
Yeah, for sure. So preterm birth refers to giving birth before 37 weeks in the pregnancy. And the reason that we care a lot about that is because babies that are born earlier can have more complicated transitions to life outside of their moms, particularly if they're born in what we call the early preterm period, or less than 34 weeks. And there are many different risk factors. I think about preterm birth as kind of two different categories. There is spontaneous preterm birth, like patients just go into labor on their own, and things that can cause patients to go into earlier labor are things like infections. We screen for things like urinary tract infections in pregnancy, but even things like COVID, like flu, if it gets very severe, can put people at increased risk of early delivery. And then there are some patients who it might be something more about their anatomies. Patients are born with different sort of shapes of their uterus. Some people have had procedures on their cervix before, where part of it had to be removed to prevent them from getting cervical cancer. That can increase their risk. Also, there seems to be something genetic about spontaneous preterm birth. So if like your mom or your sister had a preterm birth, then that makes you a little bit more likely to deliver early. There are things about the pregnancy that can put people at increased risk of spontaneous preterm birth. So if your uterus is trying to hang on to more than one baby, so having twins can make it a little bit harder. And then there are reasons that we actually recommend a preterm birth. So if a patient's experiencing a complication that is related to the pregnancy that's worsening, for example, preeclampsia, this condition that pregnant people can get during pregnancy or even in that postpartum period, but during pregnancy, if it happens early, they can have high blood pressures and signs that those blood pressures are starting to affect the maternal organs. It can affect the placenta and how well the baby grows, how well the baby gets oxygen and their heart rate. And so sometimes medically we recommend an early delivery for both mom and baby's sake. And so ways that we can decrease those types of or early deliveries is by optimizing patients' health, especially certain comorbidities, meaning like certain health conditions that patients come in with, autoimmune conditions. The better we can control them, the less chance that they'll get so complicated that we have to deal with it. A lot
Who
of
do you think is the patient? No, that's great. Like I said, I wish you could see my brain. My brain right now is like this like branching tree of like, okay, I want to ask her this. I want to ask her this. Like you're gold. Who is, and I know that it's a broad question, but I'm imagining a listener who's either a newly pregnant person or someone who's planning to be pregnant, and they're trying to understand, like, am I high risk? Should I ask my OB to refer me to a high risk OB specialist even before I get pregnant or early in my pregnancy, knowing that, yes, there's conditions that I, as the OB, will, be able to assess at time and eventually make that referral. But who's the person who, should ideally see someone like you either before they get pregnant or early in their pregnancy?
And I will say I'm a huge fan of preconception visits, and they don't always have to be with a maternal-fetal medicine doctor. Like I think what you mentioned, Anna, is that like people who, if you have an OB-GYN, talk to them if you're thinking about becoming pregnant, because generalists are really good at sort of, helping patients optimize their health before becoming pregnant and identifying those who would benefit from seeing a high-risk pregnancy specialist. I would say patients who have very complicated medical histories would if they had a history of cancer or active cancer that they're being treated for, or autoimmune conditions like lupus, which can affect many different organs in the mother, or if they've had a history of a pregnancy complication. Those are patients that really benefit from talking to a maternal-fetal medicine provider in advance of their pregnancy. If you, in the setting of, some of it also depends on kind of your healthcare system. So I think at UCSF, we're really fortunate we have a large maternal-fetal medicine division. So we have capacity to see, patients for preconception visits for, diabetes. But if your diabetes is well controlled, then typically a general OB-GYN can talk through kind of the ways that pregnancy might affect your blood sugars and how what medications are safe or unsafe to continue to use in pregnancy. Along those lines, like if you are on medications, it's always good to review those in advance of trying to become pregnant, because I always caution patients of stopping, unless somebody's told you to stop your medication once you become pregnant. Things like chemo, certain things are very known to be toxic in pregnancy. But if you're unsure, talk to your provider first before stopping a medication, because many medications are safe to continue as long as patients are counseled about sort of risk benefits in the setting of pregnancy. There are some things I'll just say like that. I think some patients I've seen, or even talking to friends, that they feel like, I think I'll need a high-risk pregnancy specialist because I'm going to be over the age of 35 when I become pregnant. And it's true that being more mature moms, so over the age of 35, but more particularly over the age of 40, does increase the risk of certain pregnancy complications, the risk of the baby having an extra chromosome, which can cause conditions like Down syndrome, or increased risk of preeclampsia, diabetes in pregnancy. But those risks are very well managed by a midwife to identify those risks, or OB-GYN in terms of managing those complications if they come up. So I wouldn't say that if for age alone that a patient needs to see a maternal-fetal medicine specialist, but you can always talk to your OB-GYN about the pros and cons.
Yeah. Well, that last statement means a lot to me. I'm not going to age myself on this episode, but I'm on the 21. Other side of, I'm 25. I'm 25, actually. I'm 25. I'm a little older than 21. But no, that's great. I think that there's so much information out there, and I think information is really empowering. I think, the goal of a podcast like this is to present information that's been either vetted by people in healthcare that I trust, or coming from women themselves who've had their experiences to share, and there's truth in that. But sometimes it is this information overload. And so you sometimes get this information. I have many patients who come in, especially because we practice in the Bay Area, who come in and they're like, oh, I'm geriatric, I'm advanced maternal age, I'm elderly, all these different terms. And they come into their pregnancies with like an anticipatory, like, bit of fear. Right? Around that. So I think it's really nice to say, hey, check in with your OB, or check in with your OB-GYN doctor or your midwife. Like, these are people who are going to help you understand, based on your medical history, your surgical history, your meds that you're taking, where you fall in that trajectory, or that continuum rather of pregnancy risk. So that's great. Very helpful. So if we take a step back to your PTBi work, you had alluded to kind of risk factors for preterm birth, generally speaking, but it sounds like a big part of that work was related to the health disparities in preterm birth. Can you tell us more about the data around health disparities of preterm birth, and what you've learned from all your research?
Yeah, so I think what has been shown in many studies is that unfortunately the burden of preterm birth is higher among our Black birthing population and also other minority groups. So specifically in the Bay Area, Pacific Islander population is actually at higher risk. And when we look at like American Indian populations, they also experience higher rates. And it's not because of anything inherent to like the DNA or biology or of these different communities, but really more related to the racism and other disparities that our communities are facing. I think that we know stress and things like racism can affect kind of material resources like access to adequate healthcare prior to becoming pregnant, during pregnancy. Also impact like the experience of patients once they access care. So experiences of racism, of not being heard. I think we've even heard that from, celebrities, people like Serena Williams, who had a history of a pulmonary embolism before, named that she was having chest pain after a C-section and still had to advocate for herself to get a study that was very clearly indicated. And so I think there is that. And then there's also just the general stress of racism. We know that stress and pregnancy and mood changes that can happen directly impact people's biology and can increase the risk of challenges. And so I think it's been really encouraging to see more of this information be in the hands of the public because of media, because of stories, because of celebrities coming forward about experiences that they've had. And I think it's also really hard. Like I work in a couple of different spaces that center the role of racially concordant care to help patients who are interested in that type of care paradigm, where Black identifying patients want to see Black providers. In a racially conscious way. It's not meant to like segregate care, but really to like allow for spaces where people can name racism, talk about how those experiences are showing up, maybe have shown up for them in the past and caused trauma in their prior medical encounters, but also how can we hold space for them and provide advocacy resources and things as they're navigating their pregnancy. But it's really hard to have people say like, I'm scared about being pregnant. I'm scared about dying. Like, I think it's very rare for me to hear that from other patients, with the exception of like those who have like major cardiac issues, things that like are very life threatening, but just the fact that like being born Black can carry so much increased risk is really hard. And so I feel like, it's important for us to name and identify those things, but really also highlight like the joy of the Black births and the community that is really like has been even there's a long history of like Black midwives and like the role and critical role that they played in supporting healthy Black births, and how do we sort of help people feel encouraged that this is still such a beautiful like magical process, and also be mindful that that journey is different if in the setting of all the adversity that Black individuals and
yeah, it's that delicate balance. I think you and I were talking about pre-recording, that delicate balance between feeling empowered with information and acknowledging that like these risks are real and these risks are not based on anyone's genetics or based on biology. These risks are inherent to being born Black or brown in the US and the kind of ongoing effect that systemic racism has and sadly might continue to have, by also just celebrating the beauty, right? Celebrating Black joy, celebrating Black birth, and making sure that we don't get like siloed and have a myopic view of only negativity too. That I find whenever I see patients for, especially their first OB visit, I'm honored that I get to care for a very diverse patient population. In that diversity, I have a lot of patients who specifically seek me out just because I'm a provider of color. You mentioned that racial concordance, and I think it's becoming more and more important for patients. And so it's not uncommon at that very first visit where of course, I want to talk about all like the basic stuff like genetic testing and scheduling your ultrasound and like, are you on your prenatals? And then, I'm about to walk out of the room and someone's like, okay, well, I'm scared of dying. Like, how is it going to be different for me? And I'm like, okay, that's heavy. That's big. Let me meet you in this moment. Let's have a deep dive. I know the things that I say, but if a patient of color shares with you that fear, how do you meet them in that space? How do you make them feel heard, make them feel encouraged? Obviously it's not easy, but what's your approach?
Yeah. I mean, I think some of it is like sitting with that and saying like, yeah, that's like our concern too. And part of the reason why I do the work that I do and that, that we have all these initiatives is because we want to change that care paradigm. Like I often will say, UCSF, we take care of patients with very medically complicated pregnancies, right? We have, joint maternal-fetal medicine and cardiac clinics and endocrinology clinics and all these spaces. And we also like recognize like that these pregnancies are complicated, not because of anything medical or clinical, but socially because of of all the inequities, historic and ongoing contemporarily, that are impacting our communities. And I think one thing is that emphasizing like, if they're worried, I want them to reach out and like making sure that they know the numbers that they can reach out to, making sure that they know that they can go to our birth center at any time, 24/7. They will be seen. If they have concerns about how they're being treated, to reach out to me. I do think, I'm fortunate to be at UCSF. We have a Black patient advocate, Cindy Fortune. So I make sure people have her phone number, her email address, and Alameda Health System. There are other sort of counterparts depending on the care model that patients are in. I work very closely with Beloved Black Birth Centering there, which is racially concordant group prenatal care, and those patients have access to a health support advocate from the Department of Public Health. So making sure that they have phone numbers and people that they can reach out to, and let them know that explicitly, like if they feel like racism is impacting their care, that we want to know about it. I think I do acknowledge like we're not perfect, like every healthcare system, but even the ones that I work in, I'm not perfect. That it is okay to name those things. It's okay to call out if they think that something is happening that's not fair, or if they feel like they're not being listened to, and to let them know that we are here for them, to give them information, to support them. I think the other thing that is important is like just making sure that they have like communities. So we were talking before we began this recording that we're both big fans of the group prenatal care, this like idea of bringing mothers together who are all due around the same age is typically how it's set up, but having the opportunity for them to get to know each other and sort of, support each other through their pregnancy journey, but giving patients information about other spaces to be connected to resources and advocates. I'm a big fan of doulas. I think that that's another way to have somebody who is knowledgeable about the experience of pregnancy and birth and the postpartum period, who can be in those spaces. And there are many times where if I'm helping patients navigate something that's complicated, like a decision around delivery timing, inviting those people to be there, inviting their partner to be there, recognizing that there's also value in them feeling that they have support people in their corner, and that those individuals are being invited, whoever they would want to be invited, and helping them make their care decisions. But it is really hard to know people are so fearful at a time where like, you want them to feel celebratory about.
Yeah. It sometimes feels like a daunting task, right? That I think you and I are both fortunate, that we are well-educated, women of color, and we walk with our own privilege, in that. And I think that, and I think part of that is also acknowledging that we're fortunate in the healthcare systems that we work in too, right? That you alluded to the things that UCSF offers that is incredible. You talked about, Beloved Black Births that is through the Alameda Health Alliance system. I, as part of Sutter Health, we have our birth equity program that's run through the CMQCC, and that's piloted at, I think, 2 other hospitals in Southern California. And so I recognize that a lot of the work that I get to see or participate in locally at my site or locally at your site still feel like we're in this like very proactive, quote unquote woke bubble, right? Like the Bay Area / California. And I think so much about, communities in other either parts of the state or communities in other states in general. I'm sure that this work, I'm not sure, I hope that this work is being taken on elsewhere. Are you aware of any other programs? I know you go to like big SMFM. I always like trip up on those letters.
It's a lot of letters.
A lot of letters. I know they have their big conference, every year. Are you aware of any like either work that's being done at like a national level, maybe the level of SMFM? Are you aware of any bigger projects as it relates to health disparities and health inequity?
Yeah, I mean, I think SMFM and ACOG, which is like the American College of OB-GYNs, and then SMFM is like our Society for Maternal-Fetal Medicine, trying to raise awareness. There are, specific work that individuals are doing to advocate or in support of efforts like the Momnibus Act, which hopefully will at some point get passed. I think, when I think of like resources that people and communities might want to tap into or look into more, I think of things like for Black identifying individuals, Black Mamas Matter Alliance, BMMA, is a really great resource for like educating yourself, getting informed. There's also, I'm forgetting, Sister Song, which has alliances with lots of different entities across the country, and can be a good place to like, start from and then find things that are local. Then I think COVID in some ways is crazy and terrible of a pandemic as it was, highlighted like that there is a lot that can be done remotely or virtually. Yeah. So you don't have to be in the same place with somebody to be connected and be able to like learn from and get support from them. I'm thinking specifically about an initiative that a friend of mine, I don't know if you know Dr. Joy Cooper, she also is an OB-GYN that's in the Bay Area, but she started Culture Care. She co-founded it with, I believe, a pediatrician, but they provide their Black physicians that provide second opinions for patients in many different states. And so I think one thing that I would say is like, if you are in a situation where you're getting care and you don't feel like it's that you're being listened to or supported, hopefully it's the case that you can get outside support, whether it's through an entity like Culture Care or some other, more telehealth focused, an initiative that can at least give you another perspective. But hopefully, people sometimes like sort of, talk about doctor shopping or provider shopping as something negative, but I think it's important to feel like you have trust in the person that's going to help you, or the team, the care system that's going to help you navigate bringing life into this world. And so, I think it's important to recognize people are going to be human, and so they're going to and the one provider, I always say to patient, like, I can't deliver all of my patients. I would love to. I'd love to like duplicate myself. So I want to build their confidence in like the health system that I'm in, like help them recognize that, it is a team effort, like we talked about before. But if they really don't feel like they're being heard or listened to try to take advantage of some of the other ways to get connected, and also to give that feedback if you feel empowered. There are initiatives like the Earth app, which are trying to provide spaces for people to give that input so others can learn from their experience, but also so that those providers and healthcare systems can hear about themselves, right? Like, I think one of the things that is true is that we always think it's like not happening in our institution. Like, we're so woke in the Bay Area, like, of course, people aren't having disparities, but when you look at your data, it's very obvious, right? Like, we see disparities in San Francisco data, we see disparities in Oakland data, and I think if we're being honest, if we look at our health systems, we see disparities. And so it's okay to call your provider out. It's okay to call the health system out. And sometimes I think there can be opportunities to serve on things like patient advisory councils, or if you have the bandwidth to help those institutions improve. Not that it's your job. I would say I wish that patients didn't have to advocate for themselves, but I think it's, unfortunately the reality is like it is an important being able to get the care that you deserve.
Yeah. Yeah. So I'd like to take a moment to tell you this is my passion project based on years of experience as an OB-GYN doctor. I aim to empower moms and moms-to-be and those in the pregnancy and postpartum care space. If you appreciate what I do, please take a moment to like, subscribe, and share with your friends so we can reach more people like you. You can visit goldenhour.fm for more information, resources, and all other episodes. If you have any requests, suggestions, or questions for future episodes, please email me at hello@goldenhour.fm or leave us a comment at goldenhour.fm on Instagram. So well said. When I'm thinking back to when you initially were kind of defining the work with PTBi and some of the things that have been shown to help, I think you alluded to, doula support, getting patients, like either families or support people involved. It makes me think so much about that phrase, like it takes a village, right? It really truly does take a collective community of people to like lift up a person. I think I've had conversations on this podcast so far thinking about, as you know, I was born of two Nigerian parents. I know you are East African. And I think at least for Nigeria, there's this like concept of the compound, like my grandmother had one property and other family members lived on that property, and the families would continue to grow, where inherently we're all just supporting each other. Now, fast forward, we live in a very individualistic society. And so things have changed over time. And so we're recreating that community now. It seems like a lot of the different resources that we're promoting in pregnancy that are really important: group prenatal care or centering, doula support, and the whole cadre of people who come in even for postpartum care. It's literally just creating community. I think one of the goals of this podcast is to create community and conversation, but recognizing that that's like that in of itself has the power to heal and to hold someone in that space. I think when we feel isolated and alone is when, not to be able to say it eloquently, that's when bad and sad things can happen, when someone feels like they're alone in a space or not even able to speak for themselves and not even having the information to know what to ask for. So, that was my own little moment of reflecting on the things that you said. But in the work that you've done with PTBi, what are the other things that you guys have seen that are potentially beneficial? I know PTBi is focused on preterm birth, but what are the other things that your research pointed out? I
mean, and I think not just my research, but to talk about PTBi ended up being sort of very broad and the type of work that was focused on. I think there was work on even like the family leaves, people being able to take time off of work in order to have their child and then be able to like raise them those first few months. We're lucky in California that there is more generous paid family leave than in other states, and the U.S. is very far behind other countries that are as high resources we are in terms of supporting parents in that time period. Housing is a big thing. I think like housing stability is a major issue. There's work that started in PTBi, but like has now, branched out through the Abundant Birth Project, but looking at like basic income as a way of addressing, health disparities and allowing people to have like less economic or financial stress in pregnancy, be able to access, things like healthy food, transportation, childcare, all these really important issues. I think environmental justice also is, something that came up in PTBi, like when we think about things like, air pollution and neighborhood safety and even climate change, like all of these things. Less so maybe, well, I don't want to say less so, but even places like Fresno, for example, where, climate is much, it's much hotter there. Those kinds of things have real effects. We might not sort of, think about it on an individual level, but likely, that those things play a role. So I think it was big. It's like pregnant. I think that I forget, and maybe I can try to come back and then sort of edit this to sort of acknowledge. But I think, some people talk about pregnancy outcomes as like a societal indicator, right? Of like, how do people take care of their most vulnerable individual, and not vulnerable in the sense of like weak or fragile, but just like it's a time where like new life is developing, and we need to be able to hold space and protect and support people through that process. And when we don't, that's a real testament to like where our priorities are. And unfortunately, in the US, we have some of the worst pregnancy outcomes of, what are considered like high income countries. And we have very wide disparities, even in places as affluent as the Bay Area.
Yeah. Yeah. I think that is a statistic that hasn't changed since I first learned it. Again, first had my mind blown and awoke to recognize how disparate our care was. And when I first kind of initially formulated my interest in women's health, because I was like, wait, what? Like those numbers are so bad. And wait, why? It doesn't seem to make sense. Like we're such a wealthy country. And those numbers, I mean, that was many years ago, again, not to age myself, but that was many decades ago. And it's still the same. And so sometimes I feel, as an obstetrician, I feel like what I constantly tell myself is like, I probably can't change the world. I can't, necessarily change what's happening at a national level, and maybe not even at a local level, but at least I can show up for my patients, right? Like my little mantra in my mind is like, okay, I'm here now. In this room for that person, whether it's like a prenatal visit, a postpartum visit, or involved in their care in the hospital and the delivery. Like that's all I can do is I can be my best version of myself for that person. But I know, and I hold on to hope with that because I'm like, at least I know I'm doing my best. But I do sometimes when I see the statistics and the data and I see that it has not really improved. And I think, maybe not to speak for you, but part of the data that honestly scares me the most or moves me the most is also recognizing that it's Black women, well-educated Black women who actually do the worst, which is me, which is you. It's like those are the data points that make me feel sometimes like a little hopeless or hope. Yeah, I have a little less hope, not hopeless entirely, but I have a little less hope. What are your thoughts about that needle moving, right? That you're in that space actively. You're at the table with, hopefully change makers, and you're presenting this data. What is your level of hope for change?
Yeah, no, I do think it is very disheartening. And I think it does feel like every year when you see reproduced statistics of like, oh yeah, Black women are 2 to 3 to maybe 4 times more likely to die in childbirth, and you don't see those numbers changing. Yeah, it just makes you feel like, what is the point? But obviously the point is the people, like each patient that we take care of and get safely through their pregnancy journey has a little one, maybe more than one, and both the patient themselves and their children contain multitudes, right? Like I think that being part of the Preterm Birth Initiative and meeting with the Community Advisory Board and recognizing a lot of those individuals on the board were Black women who had children, who had their own experiences, made me even that much more, like that they're now doing the work and, or not now doing it, but they are critical people in the community that are able to do so much more. And so I think in that way, it's like, we're helping them to be able to live their lives fully and realize their potential and their family's potential. And that is incredibly encouraging. I think one of the things that I will agree with is that I think it can't just be giving this information to, in academic journals or the CDC publishing like the same statistics. Like, I think what is moving the needle is like people, the community, through media, through other things, having that information and feeling empowered to do something about it. And I think one of the things that I'm optimistic about is like, how do we continue to empower patients? I think with things like doulas, with, one of the things that I'm starting to say more is like every patient deserves a midwife. I'm a maternal-fetal medicine doctor. Some people need to see me, of course, but like they deserve, as somebody who is centers kind of the physiology of pregnancy that's really amazing. Like even if complications come up, even if there are birth defects, even if there are other things, there's still this inherent magic of pregnancy that I think midwives, their profession really celebrates. Yeah. And my job is like, I'm the risk person. I'm like, okay, what's your risk? How do I calculate and lower your risk and offer things? And I try to celebrate the magic, but of course, there's limits to visits and time and visits and, the things that I have to get through. But I think to bring it back to the point that we were talking about, like every patient deserves a midwife. There are certain things in the healthcare system, but I also think it would be really great to go beyond that and start to give people information about what are like clinical guidelines and things. Because I think, what should be the workup that's needed. Like I think going back to Serena Williams' story, she knew she had a PE before, so she knew she needed a CT scan. She advocated for that test. But unfortunately, we hear stories of people who tell their doctor they're short of breath or have symptoms of a lower extremity DVT and like get brushed off. But what if we actually empowered them to say you should, these are the tests that are like indicated if you have these types of symptoms, or here are things that you should ask about, and holding the healthcare system accountable. I do tell friends of mine and patients, like, if you have a concern, you should send it through like a patient portal. Then it's document, you have ways that you can sort of use the system and that documentation to really advocate for some of the things that if you're worried to be able to get. And I think one of the challenges that I've been seeing and we're trying to navigate is, I think that there is a lot of fear of the healthcare system, and there's this challenge. It was actually, I read it in a paper that was published many years ago in The Lancet. It was like a series on maternal health, where in obstetrics we have this issue with like too little, too late, and then too much, too soon. So like too little, too late is like us not offering appropriate diagnostics early enough for certain pregnancy complications, or like not identifying a baby that needs to be delivered and having a stillbirth. But too much too soon is like the fact that we see very high C-section rates in the United States, and it's higher actually in the Black community as compared to others. And so more intervention is not always the right answer. But I think that there is this, in some patients hearing this, that there is this concern about like interventions and wanting to decline all of them. But that's also a tough place to be in too, because interventions can be life-saving when they're appropriately used. And so how do we, before patients are in this scenario where like they're being recommended a delivery and they're not trusting of that provider before them, how can we give them information that feels that they feel like they can trust and is like from it, that is informed, so that they don't feel like, oh, this doctor is just trying to push a C-section on them, but like actually are like kind of can navigate that, or understand that, the complications that are being discussed, like the gravity of them without. Because I think it is true that, as healthcare providers, also, we don't want anything bad to happen to patients. And sometimes that means we feel like we need to do certain interventions, and maybe that isn't the right thing in that case. And I think we, as a field, are trying to get better about preventing the first C-section, about being patient with people's labors, about all these things that we have to be held accountable, right? Like, I think that even, that we audit our first time C-sections at UCSF, and like people get, it's important to recognize that, that there is some subjectivity in how decisions get made. And I don't know. I know it's like rambling now, but I feel like, but I think some of it is like, like to get information into the hands of the birthing people so that they get to be informed, so that there's less asymmetry. Data.
No, I mean, I always say that it's humbling being another human caring for other humans. And part of that humility, though, is recognizing that there is a power dynamic, that we as clinicians hold a lot of weight in a room. And so how do we make sure that patients don't feel like there are things that are happening to them or to their bodies? Rather, they are a part of the process. They are informing that process as well. They are part of that team that we talked about, right? Where they are just as much part of that village. It's not a village just caring for them, like they're caring for themselves. And, part of one of the reasons why your response was rambling, was actually because it is so complicated. It really is multi-layered. I'm not making it easy for you. I'm not asking you simple questions today.
That have been there since the beginning of the United States.
Since the dawn of time. But this conversation is to highlight the true complexity of it all, and to not minimize it, and to recognize, why the work that you're doing and others that others are doing, the work that I hope to acknowledge that I'm doing just by serving and having these conversations in a public venue. All these things matter, and hopefully will continue to kind of move the needle, even in incremental ways. Because the problem that it's trying to solve is something that, as we alluded to, not in jest, has been around for hundreds of years. And there isn't going to be like a quick, easy solution, but we have to believe that that incremental change will eventually add up to something bigger than us, and something that we probably won't get to see in our lifetime, but we'll believe that it's going to happen. And when I think about, we talked about the things that patients of color can do, to empower themselves, utilizing their patient platforms and messaging their team, working with midwives, having doula support, and things that you and I as clinicians know that we can have continued to do. I always like to ask about allyship, right? And allies, because there are more of them than there are of us, right? And therefore, I think that allyship can go a long way. What do you say to someone who's listening right now, who's not a person of color, and are listening to this and trying to understand if they should care or why they should care, and if they should continue to listen to the rest of the episode? How do you speak to our allies out there?
Yeah, no, well, I think it's glad you're here. Hope you continue to listen. I think, and I think that the reality is the things that are going to work to help Black women have safer births are going to benefit everyone, right? I think that, Black women or birthing people are not the only ones getting doulas. Actually, I think in the Bay Area, it's skewed towards more high SES and more, of our white identifying patients who are we're getting doulas earlier on. Now, I think that that's shifting. There are a lot of services to be able to provide access for more diverse, birthing population. But just to say that the things that work well for our community are just core things that are important when you're taking care of other people. So we having respectful conversations, and even thinking about how we counsel patients and engage in shared decision making about things like lowering C-section rates, analyzing our data and looking at like where these disparities are coming up, and doing better jobs of like being responsive is quality improvement for everyone, and so I think that everyone benefits when the system is more equitable, and that and it's not, the goal is not to like bring the white preterm birth rate up to meet the Black preterm birth rate. It's really to bring everyone's rate down, and I think about initiatives like the California Maternal Quality Care Collaborative, which has done work on things like care bundles. When we focus in on the issues that are impacting the Black community more, like hemorrhage rates or like cardiovascular disease, if you integrate workflows that sort of better identify those issues, better respond to them, everyone, anybody who it falls into the higher risk category is going to benefit. So I think that people are not advocating for only helping Black birthing people. We want to make the system more efficient, more equitable, just better care. And so I think that is important. And I think when I think about like providers who are allies, like of course they can't like sub in for me for the Black Wellness Clinic because that's not their role. But I think we have been doing a lot of work around about getting information from patients around their care experiences and bringing that back to the providers to talk about like how we have conversations and thinking about, even like strategies. There are tools like the Brain, a tool that we talked to patients in the Beloved Black Centering program about, which is like a tool that I don't think is like trademarked by anyone, but I think used by a lot of doulas that sort of helps patients navigate conversations about intervention. So like helping them remember to ask about like benefits is what the B stands for, risks, alternatives, what's their intuition telling them, and what happens if they do nothing. And so helping them be able to feel more informed as they're making decisions. Because I think sometimes even myself, I know like if you're in a hurry or you're recommending something, you might not always kind of go through all the full spectrum of what people can do or what might happen if they take an alternative route. So just giving people those types of tools. And I mentioned that to say, like, when we introduce that to patients, it's important that we also inform providers outside of that care paradigm, because they, you can imagine if you're not expecting people to kind of, come back. I think that there can be some defensiveness of providers and sort of feeling like people are questioning them, when it's like, really, no, it's not about questioning what you're recommending. It's about people feeling like they're fully informed. And the reality is, we're not God. I'm like, as a person of faith, I'm like, there are limitations to like our testing, even things like fetal heart rate monitoring, which we like almost do universally in labor. We know is like flawed, but we sometimes aren't honest with patients about the limitations of that, or having nuanced conversations. And things are not, most of the time, they're not black and white. There are like a few scenarios, right? If you're hemorrhaging or like, your baby's heart rate's in the 60s and not coming back up, that's black and white. But for the most part, there's so much gray, and trusting patients to be able to like navigate their own risks. It does take time and extra work for us to make sure that they're informed. But I think we are often a little paternalistic in medicine. And some of it might be defensive medicine, right? Like, I think that we have to recognize, like, as OB-GYNs, we're like victim to, I say victim because we're an OB-GYN, but, we're subject to more malpractice cases. And of course, like, it's understandable. Like, this is a very vulnerable time for families when something happens that's not good. If like, you want to be able to point to something or point to someone or blame, but there is, and that doesn't excuse us from, being able to hold space for other people to like make decisions that are right for them. It just can be hard sometimes when patients are choosing something that's like in direct opposition to what you're recommending, but ultimately it's their lives and their children's lives. It's not ours.
Yeah. No, you once again, you said it so well. I mean, there are certain circumstances in our field that are truly black and white, like things that are so emergent that there's no questioning what the right thing is for us. But I often say that medicine is an art as much as it is a science, right? It's really nuanced. It is great. That's the power of shared decision making, right? That's the power of giving patients information that they need so that they feel empowered to make the decision that's best for them. I love I'm going to start using that, the brain analogy or acronym rather, because it is a way for patients to feel empowered in that moment of, okay, I'm processing what this clinician is telling me or this provider is telling me. How can I make a decision that's best for me in this moment? And sometimes patients are going to say, and appropriately so, no. And sometimes that no might get a little bit of pushback because maybe the situation isn't 100% emergent, but it's broaching that, right? And so, especially when I think about those moments that are most like high risk and oftentimes require like quicker decision making, it's really, it's in the hospital, right? It's on labor and delivery. And so I think some of the best situations are meeting that care team early. I think something that you alluded to is midwives are great and all patients need midwives. I am fortunate to work in a collaborative practice just like you, where physicians, MDs are working alongside midwives. And so that unit, if there's a patient that we're already worried about, might need kind of higher risk intervention by a doctor like myself, like that unit should meet that patient early on. There should be early conversations of like, hey, these are things that we're worried about. This is what makes, either your pregnancy higher risk or this is why we're worried about the baby. So that it doesn't feel like this is like impending moment where suddenly everything changes. I think when we reflect on trauma, and that's something that I wanted us to talk a little bit more about, when patients feel traumatized by an experience is again, what we said, when things are happening to them and not necessarily like that they don't feel like they're a part of that process. And I think there's so many things that we can do as clinicians to minimize that experience of trauma by having these conversations frequently and not talking at the patient, but talking with them.
Yeah, I think there's a lot of trauma that people feel that I think could have been avoided with better anticipatory guidance in terms of even just like intervention. Like I think some people, I encounter patients who feel like a C-section is very traumatic, like having a C-section for their first delivery. And I've started to tell people more and like, or, prenatal care, like, 1 in 4, I mean, even at a place like UCSF or the places where we work in the Bay Area, like which have lower C-section rates than nationally, still a very real chance that for some reason you might need a C-section. Instead of it being like a surprise or a shock, or patients feeling like if I failed or I did something, like they think maybe I didn't advocate for myself or maybe I didn't, recognizing that there is just this real probability of certain things occurring or other things like the babies having changes in their heart rate and sort of, the fear that comes with that. Or we have mentioned this condition called preeclampsia a few times, which can be life-threatening, but generally is something that we are able to manage very well, but still can be scary if you didn't know that it was a possibility to all of a sudden be recommended medications, hospitalization, maybe an earlier delivery versus if you've heard about it in advance. And I think about things, I often use this analogy of like, whenever we get on a plane, we're like forced to watch this video or, or watch a flight attendant talk about an oxygen mask dropping down or like where the emergency exits are. And most of us have never probably ever had to use a life vest or the emergency exits, but we've all seen those videos. And yet most people, like a lot of people might come onto labor and delivery and never watched a video about a C-section or never sort of heard about forceps or a vacuum for an assisted vaginal delivery, even though that happens way more frequently, is much more likely to be something that's offered to them than a life vest. And so it's like, it's I think there is a huge role for education and making people informed, not scaring them, but talking about it in a way where it's like, hey, these are tools and they might be used. And I really have appreciated, models like Centering Pregnancy or group prenatal care, which provide that space. I was saying earlier to Autumn before we got on the call, like that one of my favorite things to do is to join groups when they're talking about interventions in pregnancy and, actually bring forceps, or like show them these instruments and like have time to talk about it when they don't need it. And they still patients will still say it's scary to think about, but it's in the same way, it's like not fun to think about an oxygen mask dropping down. But imagine if that oxygen mask dropped down and you had no idea, right? Like if you would think like the plane is being down instead of thinking like this is actually for my good. Let me put this on and then put it on the person next to me. So I think giving people information can help them understand, like, I heard about this fetal scalp electrode. I understand what it's for. It's not like they're trying to hurt my baby or they don't know what's going on. It's actually a tool that they are trained in how to use, and they use it in certain scenarios. So I think that's what I mean when I say some trauma is avoidable. And then at the same time, like if a plane goes down, that's going to be traumatic. Or like if you need to use your oxygen mask, like that's still, we still have to acknowledge like there can be like very real challenges that come up. But I think some of the things that as providers were, I would say sometimes surprised that patients find traumatic is because it's day to day, like bread and butter things for us. Yeah. But for that patient, like they had no idea, that they could bleed a lot and need a blood transfusion. Like that is probably the sickest that many people will be in their whole life. Like if they overall came into pregnancy very healthy, this is the riskiest thing that they've ever encountered. And well, for us, it feels like, oh, it's very manageable. We responded. She got 1 unit of blood. For them, that is a plane crash, right? Like that is like they feel like they were sideswiped. And so it's like, how do we help people feel more confident that like it's something that we know how to manage, is something that can occur, help them not feel so alone in those experiences, and help them feel better prepared without overwhelming them or scaring them about all the things that can go on. And I haven't figured it out. I joke with people that I'm happy for them to steal my ideas, but I do think it would be really great to like make videos, and we're talking about doing some of that. So if we are able to create some content, we'd love for you to advertise it on this site or in other spaces, but just like, showing people these tools, showing them how teams respond, that would be great. Maybe we should make a TV show.
Yeah, maybe. No, but I mean, even hearing you speak, I think about so much of this podcast was born of my frustration with the healthcare system, that it's an honor to work in this space. And I love my job. I'm honored to do my job, but I also recognize that the entire healthcare system that is thousands of times bigger than you and me is a broken one. It's a flawed one. And it means that I oftentimes feel as a clinician who earnestly gives her heart to each and every one of her patients, or as much as I can. I recognize that I can't do everything. I can't say everything because I'm in a system that limits my time with my patients. It limits how many patients, it maximizes how many patients I must see in a day. And so I think about things like what you're mentioning, like that 5-minute video that everyone watches, or at least passively observes on the plane. I would love to have that time to show a patient like all the possible tools of things that they might see on labor delivery, either emergently or as part of the process. And I don't. And I think that to me, this podcast is, again, it creates more space. To me, this podcast is a continuum of the one-on-one visits that you and I have with patients, either in pregnancy or postpartum, so that these things can still be informative. But I also think that, it also should be a partnership of ideas that you have, like creating these videos. Like that would be great. That would be great to say, hey, I only have 10 minutes with you today, but there's this great video. Here's the link. Like watch it, like so that you're, as familiar as you possibly can be about things that can happen. There's just so many things, right? There's so many things that we can do in conjunction with our limited healthcare system. I think that's why I'm so inspired by people like you, and recognizing that if we maximize our potential within our roles in that system, that's okay. But let's be creative about the other things that we can do. I'd love to be in one of those sending groups where Dr. Martha comes through and it's like moving the patients around. And that's a great idea. I'm listening to you. I also lead a centering group for our team. And I'm thinking about, most centering groups are probably somewhat similar, where one of the last sessions is talking about like possible labor interventions. I'm like, oh, I need to get more hands-on. I need to step it up.
I joke it's like my actress like opportunity. I'm like, okay, And I will give credit. I should give lots of credit to Jay Sharan, who like helped co-found Beloved. And I'm not going to give away like our scenarios, but like I think like that every day we like move people around. We call it batching, but take them to the OR quickly. And so just helping people realize like this might happen. And it's so fun to be in that space because some of the patients are not first time moms and they're like, that's exactly what they do, or they like sort of, feedback of like, yeah, or I like was in my sister's birth and that happened, and so these are real things that come up a lot for people. And I think the nice thing about this, hopefully, maybe even by the time you release this this episode, maybe we'll have something to share about an ETA for some of these things. But it's like it doesn't need to be created by us. Like there's so many creative people who want to do work in the healthcare space and like who are passionate about birth work. And so I was just actually in a hackathon that PTBi sponsored with Twilio to like think about Black maternal health and like how tech could, like how could you use an app or something? And the ideas that were pitched were like amazing. I was like, I want all of them. And like, and so I think if people are listening to this and they are in a different space, maybe they're an expecting mom or thinking about becoming pregnant and work in a different industry. If you can think of a way to, if you're a designer, if you're like you find out about, these different like Black Mamas Matter or like your local ACOG, or it's, like there's so many different people, that we need to like actually move the needle on these issues. I think media played a huge role, people sharing their stories, the articles that came out about people who like lost their lives due to these this, I guess we'd call it now like endemic crisis in maternal health. And so, there's just so many different ways to get involved. So I think it would be a great way for somebody who's creative. If you're a video editor or something like that, you want to support, reach out.
No, but it is true. And again, not to continue to plug the podcast on the podcast, but it's true that the goal of something like this is to like get people thinking that there are probably people listening who like they are, product designer at some tech company and never really thought that skill set, which is so amazing, could be applied to something that they either were directly affected by or saw a loved one affected by. I think, and we talked about allyship before, like it's about all of us, everyone, whether you're a person of color, like a woman of a woman, like all of us can get involved in some way. It's going to take a bigger involvement to move that needle, whether it's incrementally, slowly over time or like a big push. I think we're pretty fortunate in the Bay Area that there's a lot of natural creativity percolating in the Bay Area. And I hope that these like partnerships organically happen. There's so much great work that you guys are doing with the PTBi, and there's so much more that you're doing. So don't you worry, girl. I'm inviting you back. You're going to be a repeat guest because there's so much. We talked about reducing the or preventing the first C-section, right? That in itself is a whole topic. I would love to talk to you about inductions and the Arrive trial, right? There's so many things that are so important to not only us as clinicians, but more important to, again, the patients that may or may not be informed by these papers or these research findings. And how can we distribute that information in a way that, ultimately leaves people feeling empowered and engaged.
Yeah. And like supporting people's autonomy. Like I feel like, I don't know if you get this question, but I get the question a lot of like, do I have to do something? And I always say like, hey, I'm not a judge. I don't like give out sentences or tell people that they have to do anything. Our jobs are really to like empower people with information and access to like tools or interventions and support them in making the decisions that are right for them. And there are going to be times where it's like, there's an urgency to making that decision, or like, we have to be very clear about the things that are more life and death. And then there's so much that there is space to like be, shared decision making. And I think it's like one of the hardest things about our jobs, but I think it's like the part that I like love about it is that it's so value centered. It's like really like you do have to kind of get to know your patient and understand like what are you prioritize, or like what are your fears, what are your hopes, and really work with them to design that plan moving forward. It's a very I couldn't agree with you more about just like being so honored and humbled to do this work, and sometimes discouraged by like all the things that our patients are navigating, we as providers are navigating. We didn't even talk about insurance, but like, oh my gosh, insurance. I know, I know people who work in insurance and I know they're trying their best, but like the barriers there's just so much, but there is like still every birth is so amazing. Like I keep coming back every time because I'm just like, it's just, there is nothing like it. And like none of us would be here if we didn't have our moms kind of go through this process. And so it's like really powerful to be able to support people. And I would say, the thing I would say back, I know it's not my podcast, but I do think we can really change things, not just for our patients, but like on a larger level. Like I think in being part of PTBi and then even in, other work around disparities and things is like our voices are so important, and patients' voices, sharing patient stories. I think that ultimately, like the people who are running our hospital systems, the people who are running local government, state government, national government, even international, right? They're people. And so, there are ways to shake things up or change things. I'm really encouraged that like Medi-Cal is now covering doula, like there are things that are really happening that are exciting to see. And if folks are in the Bay Area and want to, reach out to me, I'm terrible with email. So like sometimes you have to send it a couple times, but, reach out to Anna. She knows how to get in touch with me. But, there's just, I think that there is opportunity to move the needle, not as quickly or as much as I think all of us would hope, but it's definitely possible.
Yeah. Well, Martha, very selfishly, I had asked you to be a guest, not only because you're a dear friend, but you always refill my cup. And I feel so much more hopeful with this conversation. You're right. Birth is beautiful. We are honored that we get to be a part of it. And there are so many, people that get to be a part of it in their own ways. Again, whether it's directly as the mom to be, or, someone who is now postpartum, or someone who's just listening because they love someone who's planning to birth. And I think that you said it so well. It's truly an honor to work in this space, but it's also just truly an honor to talk with someone who's as passionate as you in this space. I don't want to be one of your patients one day because I hope I'm not like really high risk besides my age. But I think
I could be your doula. I've been through some doula training.
Yes. But no, I think that you're a gift to every patient that you touch, but you're also a gift to the organizations that you serve. So thank you so much for giving us your time today.
Yeah, thank you. We're always learning from each other. So I feel humbled, excited to not watch my own podcast because I think it's going to be very awkward, but excited to kind of to see all the information that you're going to unlock for people. I think it's going to be really exciting, and happy to.
Girl, there are many future episodes starring Dr. Martha Tesfalul. Well, thank you again, Martha. We really appreciate you, and have a great evening. Thank you very much for listening to The Golden Hour, the podcast community where moms and moms-to-be can hear stories from other mothers and learn from top experts in pregnancy and postpartum care. If you enjoyed this episode, please take a moment to like, subscribe, and share with your friends so we can reach more people like you. You can visit goldenhour.fm for more information, resources, and all other episodes. If you have any requests, questions, or suggestions for future episodes, please email me at hello@goldenhour.fm or leave us a comment at goldenhour.fm on Instagram. Looking forward to seeing you in the next episode. Until then, stay golden.